Us today. Oop, okay. Um, I'm going to pull up some slides, but we'll do a brief introduction on just a little bit of our background, who we are, and where you can find us. Let me pull up the slides first. Are you guys able to see those slides?
Yes.
Yeah? Okay. So first off, I'm Dr. Steph Glacier. I'm a urologist who specializes in pelvic reconstruction, pelvic medicine, pelvic floor disorders, and neurourology. I practice out of Garden City. And so this topic is very near and dear to me. I have a lot of patients who struggle with different neurologic conditions. Hopefully you'll get something out of this talk and, hopefully we'll have good discussion at the end. I think my colleagues were going to just briefly introduce themselves as well, and then we'll launch into the talk.
So hi everyone, I'm Dr. Ali Tabakin. Like Dr. Glacier, I'm also a urologist who specializes in the same thing. My office is mostly located out of Great Neck, because I mostly work out of a urogynecology practice, but when I work with Dr. Glacier and Dr. Lee, I work at their practices with them. So it's very nice to meet all of you.
Hi, very excited to be here. It's always nice to be in touch and in a more intimate setting with our community as opposed to in our office, and where the timing sometimes is under pressure. My colleagues here, Stephanie Gleitcher and Dr. Ali Tabakin, we are urologists who chose to spend extra time in specializing in things related to the bladder, including neurological conditions. So we represent probably about 5% of all urologists. And so happy to be here, happy to talk a little bit about some of the manifestations of Parkinson's disease. Thank you, Dr. Gleitcher, for leading this.
All right. So let's get into our conversation for today. So again, we're going to talk about Parkinson's disease and dementia specifically, and the urinary manifestations that we commonly see. So just a brief overview. We're going to start off just discussing urinary function, give you a little bit of background about what it takes to have normal voiding. Then we'll get into a little bit of Parkinson's disease and how urinary symptoms manifest when someone's diagnosed with this. Segue into dementia and those urinary manifestations. And then we'll go over some management options for people who are suffering from some of these conditions and symptoms. And then hopefully we'll have a really nice question and answer session. So, normal urinary function. The bladder does two things essentially. It stores urine and it empties urine. And in about 90% of the time, your urine is being stored. And then when you make the decision that it's time to empty, the bladder empties. It seems simple, but a lot actually goes into making sure that it's normal voiding or normal bladder emptying, normal bladder holding. You need to have three key ingredients. You need to have intact cognition, so decision making over when it's time to empty your bladder, when it's time to go to the bathroom based on the signals that you get from the bladder. You need to have intact neurologic pathways. So these are the signals that go from the bladder up to the brain and then back down from the brain to the bladder. And then you need to have intact anatomy. So, if you need to make sure that your bladder is functioning properly, that there's nothing making it hard for your bladder to empty. And really, these three things are crucial to have normal urinary function. And so, when does it become urinary dysfunction? You might have guessed. Basically, if you have disease or insult to any of those three areas, and it doesn't have to be all three, even just one. So, if you lose cognition, the ability for decision making, that will impact how your bladder functions. If you have some sort of neurologic insult in the spinal cord or anything really disrupting the nerves that go to the bladder, and there's so many, that would lead to some sort of bladder manifestation. And then anatomy. And so, again, you need to have these three things to have healthy urinary function. So, Urinary dysfunction, the bladder has to be able to hold urine, but it also has to be able to empty that urine. And so there has to be a connection between the bladder and then the outlet, which is basically what we call the urethra, or where we empty urine from. And so if there's some sort of disconnect there, you'll manifest with symptoms. We know that there are numerous causes that cause urinary dysfunction, and a lot of them have to do with neurologic conditions or injury to nerves. And so, again, we have to consider the impact of Parkinson's disease and dementia on these urinary symptoms. And so, just a little bit of background about Parkinson's disease. We know that this is a neurodegenerative disorder that affects one specific part of the brain. And what we see is that there's a loss of a specific type of neuron, the dopaminergic neurons. And so, what this leads to is basically a disruption in the neurologic pathways. And how it manifests clinically is basically symptoms of muscle rigidity, tremors at rest, difficulty walking with instability and balance issues, basically just a slowing down effect of movements, which we call a bradykinesia. And there can even be cognitive changes as well. And so, how does Parkinson's impact the bladder? Studies have shown that really, depending on the type of study, somewhere between 30 to 75% of individuals that were diagnosed with Parkinson's will have some sort of bladder manifestation. And the most common bladder manifestations are usually things that have to do with overactivity. And they've done a lot of bladder studies on patients with Parkinson's, and they find that these patients have the feeling of urgency. So when you get the signal that it's time to go to the bathroom, you have very little warning and time to actually get to the bathroom. And if you don't get there in time, you develop something called urge incontinence, where you'll actually have leakage of urine. We also see that patients go to the bathroom more frequently. So when you might have been able to hold your urine and go 4 or 5 hours in between voids, now you might be going like every hour. Some patients will go every 30 minutes or feel like they have to go that frequently. And then another big symptom that we see is nocturia, which is really just a fancy way of saying nighttime wake ups to go to the bathroom. And so patients end up suffering from sleep and not getting enough sleep because their bladder is waking them throughout the night. Those are the most common manifestations, but there's still other things that we can see. So, because the neurons or the nerves are affected, what we'll see sometimes is decreased bladder sensation. So, what does that mean? As the bladder's filling, you might not be feeling it as much as you used to, which gives you less time to actually get to the bathroom when you finally do have sensation, because it usually means your bladder will be fuller when you get there. Or you might have difficulty just knowing when it's time to go to the bathroom. The other thing we see is a slow relaxation of your sphincter. So, your sphincter is what gives you your continence or your ability for decision making of when to go to the bathroom. And sometimes it can be challenging to empty the bladder because the sphincter is just slow to relax. It's a muscle, and we know the muscles are affected in Parkinson's disease. The other important thing to keep in mind in patients who have Parkinson's is that we can't necessarily attribute all of the urinary symptoms to Parkinson's disease. Sometimes there are other reasons why people have urinary symptoms. There could be pre-existing bladder and outlet issues that are contributing to symptoms. So, an example would be men as they get older. We see a lot of men who have prostate issues. And so that's something that we have to keep in mind, when we're managing patients who have these diagnoses. We can't overlook the fact that there could be something else driving their symptoms, and they might benefit from one treatment over another. And so, one of the really important things that we do as urologists who specialize in neurourology is special bladder testing. And that really is a very powerful tool for us because it helps us define what the issue is that's driving the urinary symptoms. This test basically tells us how the bladder functions. What does it look like when we're filling the bladder or the bladder's filling? Is it that you can't hold a lot of urine? You have a smaller capacity? Is it overly active? And what does it look like when you're trying to empty your bladder? And so this really is a powerful tool that helps guide the treatments that we recommend for you. So urinary symptoms cause significant burden in patients with Parkinson's disease. And, again, this isn't just isolated to Parkinson's disease. This is really anyone who's suffering from these types of urinary symptoms. But they've done studies looking at patients specifically with a diagnosis of Parkinson's disease to assess how do their symptoms, their urinary symptoms, impact the quality of their life. And they found overall that they really do decrease the quality of your life. There are a few domains that are affected when you have urinary symptoms: psychological, behavioral, physical, and economic too. It can get expensive with these urinary symptoms. From a psychological standpoint, we think about the stress of having, to go to the bathroom when you're out or with friends, or leakage. There's embarrassment. There's also bother. Going to the bathroom suddenly went from being something very simple to like very complex. There's also depression. Some patients will isolate and, really withdraw because of these urinary symptoms, and anxiety. These are known phenomenons that happen in patients with Parkinson's that are suffering from urinary symptoms. As far as behavioral go, patients will avoid the activities that they once loved doing, and they'll find ways to cope. So we have a phenomenon called bathroom mapping, where before you feel comfortable going out, you have to know where all of the bathrooms are that, nearby, so that there isn't an accident, and, you won't feel the anxiety of being out and being in a bind. There's also physical manifestations. So if you're getting up throughout the night to go to the bathroom, you're probably suffering from sleep deprivation, which can impact your daily living. It takes a toll on activities. Again, you might opt not to be physically active or partake in activities that you once loved, hobbies, get-togethers with friends, because again, your urinary symptoms just impair the experience. Intimacy, that's another big one, especially if you're concerned about incontinence, or that's definitely something that impacts the quality of your life. And travel, having to worry about having to go to the bathroom or packing pads, and all these considerations. From an economic standpoint, you rack up a lot of doctor visits, sometimes even medications, and pads in themselves. If you are having leakage, those actually cost a lot of money. So there's significant burden associated with urinary symptoms. So when it comes time to pick a management option for patients, and again, this is just specific to Parkinson's, but this is really how we approach it with every patient. These are just some specific considerations for Parkinson's patients. So tremors, based on the tremor, what's within the scope of, given dexterity as a choice of treatment. Mobility, that's a big, important consideration. Cognitive changes, ability to tend to oneself or make these conscious decisions. And then medications. So again, making sure that we choose, if it is a medication that isn't contraindicated with one of the medications you're currently on. And so there's a lot to consider when you're making medical management decisions, or just management decisions in general. But ultimately, the key goals of bladder management for patients with Parkinson's boil down to three things. We need to understand why you're having the symptoms you're having so that we can adequately treat you. We want to optimize the quality of your life, because we know just how important that is. And we really want to diminish the impact on daily living. So we're now going to segue to the next part of this talk by my colleague, Dr. Tabakin. I'm going to mute myself.
All right, can everybody hear me? Okay, great. Well, that was an excellent overview, Dr. Glacier. So a lot of what Dr. Glacier just said is going to also apply to this portion of the talk, which is a little shorter. But now I'm going to focus a little bit on dementia and the bladder. And as a lot of us know, dementia can be something that occurs in patients with Parkinson's, although not all patients with Parkinson's have dementia. So there's definitely going to be some overlap in what we talk about. Next slide. What I'm going to focus about for this portion of the talk is incontinence as it relates to dementia. There's a lot of different types of bladder issues that somebody who has dementia can develop, but a lot of them will always go back to incontinence or cause incontinence. And so I will be talking about that shortly. Like Dr. Gleicher mentioned, incontinence is defined as the lack of voluntary control over either urination or defecation. And today we'll be talking about urinary incontinence or leakage of urine when you don't want to leak. So 60 to 70% of patients with Alzheimer's or dementia of other types may develop incontinence over their lifetime, and this can happen in both men and women. Importantly, though, the treatment and management of incontinence really depends on what the cause is. There's a lot of different causes. Some of them are related directly to dementia. Some of them are not related to dementia. As urologists, it really is our job to kind of figure out what that cause is, and if it's related specifically to dementia or if it's something anatomic like the prostate, etc. Next slide. All right, so let's talk about some of the causes of incontinence that are not related to dementia. So these can really happen in anybody. Urinary tract infections, or when you have bacteria in the urine that's causing symptoms, things like burning with urination, urinary urgency, that sensation that you got to run to the bathroom, things like that, those can cause incontinence, or that is one of the symptoms of a urinary tract infection. Constipation can cause urinary tract infections, as well as prostate issues in men. If you have an enlarged prostate, something that can happen is if it becomes too large and kind of blocks that urinary channel from being able to be open, people can leak out urine slowly over time, even though they're retaining a lot of urine on the inside. Some of it just kind of drips out. But even despite that, men can have incontinence not related to their prostate as well. And then finally, certain types of medications may also be related to incontinence. Similar to prostate issues, certain types of medications can cause people to retain urine or preventing them from being able to urinate normally, and that can lead to incontinence as well. Next slide. So briefly, just managing these specific types of incontinence. For urinary tract infections, those are treatable with antibiotics. For a lot of patients, though, some people will get them regularly, several times a year. And so sometimes as urologists, our role is to put people on a preventative schedule of medications to prevent urinary tract infections from recurring. Constipation is another, like I mentioned, is another cause, and we can recommend stool softeners or also certain nutritional aspects that can help prevent constipation, like eating adequate fruits and vegetables every day. For enlarged prostates, some patients are eligible for medications. Certain medications kind of help open up that urinary channel, while other medications help shrink the prostate. There are catheters that can be used, and there's also certain surgical procedures that even some patients with dementia would be candidates to have, depending on some of your other patient factors. And then finally, for medications, it's very important that your doctor reviews the medications that you're taking to make sure that you're not on something that may inadvertently lead you to having incontinence symptoms. Okay, next slide. So now let's talk about some of the causes of incontinence that are related specifically to dementia. Some people with dementia may have some of these symptoms, all of them or none of them, and this can be very difficult to treat, especially for caregivers. So some of the dementia-related causes of incontinence are cognitive reasons. So the patients, because of the forgetfulness and changes that happen to memory, have certain cause, some of these reasons cause dementia, and then other ones are related to mobility. So for cognitive reasons, some people will experience dementia, or some people with dementia will experience incontinence because they're unable to react to the sensation of needing the toilet. Sometimes they're unable to communicate their need for the toilet. Sometimes people may not understand a prompt asking them to use the toilet. So if someone says, let's go to the bathroom, they may not be able to process that. Some patients may forget how to go to the toilet, or they may forget to remove their clothing or how to remove their clothing. Other patients may not make attempts anymore to find the toilet, whether that's related to depression, lack of motivation, or distraction. And then finally, other patients get disoriented and then they just cannot find where the toilet is. In terms of mobility, some patients can't make it to the bathroom fast enough. If they're wheelchair bound or, really aren't very mobile themselves, they may require multiple people assisting them to get up. And by the time that happens, they may not make it on time, coupled with the fact that a patient may not be able to express that they have to go. And so all of these things together can cause incontinence. And in some patients, they will have causes of incontinence related to both their dementia and some of the other previous non-dementia related causes that we discussed. Next slide. So we're going to now talk a little bit about some of the treatment options for incontinence, and I'll start with some of the more conservative measures, and then Dr. Lee will talk about some of the other things that we recommend. So we can start simply when treating incontinence. Sometimes it's just as simple as diet and lifestyle changes, establishing routines, wearing appropriate clothing, or using certain continent devices and products. So for diet and lifestyle, we recommend staying hydrated. If you are dehydrated, you're more likely to develop a urinary tract infection. You're more likely to be constipated. On the note of constipation, like I mentioned before, stool softeners can help prevent constipation, and also proper nutrition, increasing your fruit and vegetable intake, and natural fiber can help to prevent constipation. Avoiding bladder irritants can also be very helpful in some people. Certain types of bladder irritants can make you feel like you urgently need to go to the bathroom. Those are things like caffeine, carbonated drinks, alcohol. So we usually recommend that some patients curtail or lessen the amount of those sorts of bladder irritants that they're having if urgency and not being able to make it to the bathroom on time is one of their symptoms. Establishing routines can be very helpful. In dementia, a lot of people really lose that ability to tell the difference between morning and night, and they lose those routines. So this can be a little bit more dependent on their caregivers, but it can be helpful to eat and drink at regular times, breakfast, lunch, dinner. Stop eating and drinking 2 hours before bed to prevent nighttime wetting, and going to the bathroom after every meal. In terms of appropriate clothing, it can be very helpful, particularly to caregivers, but also patients if there's easily removable clothing so you can get it off in a timely manner. And then also doing things like avoiding buttons and zippers, especially if there are hand dexterity issues for a patient. Lastly, there are things called continent devices or continence products. And so one of those things are incontinence pads or pants. So these are, very thick pads, or like I said, pants that can really absorb a lot of urine. If you do leak urine, and incontinence is something that you are okay with having, but want a very conservative approach. There's also bed pads and mattress protectors, which can absorb the urine. In women, there's something called a PureWick, which is a suction device. We have a picture on the next page. So if you leak urine while you are in bed and you have this PureWick device, it will suck up the urine. And then for men, there are things like condom catheters or incontinence sheets. And we'll go to the next slide to show what that looks like. So the condom catheter is seen on the left, and you can see it looks like a condom or a little sock. It goes over the penis, and the urine drains out into a bag. And so this can be removed. It doesn't require that you put anything inside of the urethra or the penis. So it's non-invasive. It can be, they can be exposed or disposed of. They're disposable devices. Indwelling urethral catheters are catheters that go inside the penis. So if you are a patient that's ever had urinary retention where you can't pee on your own, that's the type of catheter that they would put in. So it goes inside and it serves as a drain. So it's a little tube that drains the bladder so the urine can get out. That can be the treatment for incontinence in some people, although typically not recommended as a long-term solution in men or women. Then there's something called a suprapubic tube, which looks the same thing as a urethral catheter, but instead it's put into the abdomen. So it's a little tube that goes into the abdomen to drain the bladder. That can be a permanent solution to certain people, especially if they can't really empty their bladders well and have incontinence. And then it is a little bit easier to change because catheters need to be changed approximately every month. And then finally, the vacuum suction sponge or the PureWick. So that's shown on the right side, and it's that blue tube looking device, and basically it goes between the legs. Typically it's used in women. And so if you urinate into the bed or wherever, or the chair, wherever you're located, it will suck it up. Now, the caveat here is you need some sort of wall suction. So not everybody has this as an option to them, but if you're in a nursing facility or something where they have this could be an option. Okay, and then next slide. So this is the last slide of this portion of the talk. But so if conservative measures fail, there's a lot of other things that can be done. And for incontinence, medications is an option for certain people with certain features of incontinence. So if you are someone that has urinary incontinence that is urgency related, so that means you can't make it to the bathroom on time, but this is not necessarily related to mobility. It's more that when you gotta go, you gotta go. That's the sensation that your brain is sending. There are two types of medications. One are called beta-3 agonists. The other group is called anticholinergics. Anticholinergics have been associated with cognitive issues, so that may not be what's recommended in patients with dementia, but nevertheless could be an option for certain patients. And then there's something called overflow incontinence, which I kind of alluded to at the beginning. That's when you're dribbling with a full bladder. So if you're a patient that has urinary retention and you're holding on to a lot of urine and just little bits are coming out and out, there are medications called alpha blockers, which kind of help open that channel. I didn't mention this on here, but there's also certain medications that can also help in men shrink the prostate, that can also help with overflow incontinence. So this kind of concludes this part of the talk. And I think Dr. Lee is going to talk to us a little bit more about procedures for incontinence.
Thank you, Dr. Tabakin. Everybody see and hear me? Okay, great. So this part goes into a little bit more on procedural treatment. And one might ask, why do procedures when you could just take the medicine? And unfortunately, the reality is the medicines oftentimes either don't work, don't provide enough benefit, or their side effects become intolerable. And so the statistics say about almost 75% of patients end up stopping a medication because it doesn't do enough, or it causes a side effect, or it's too expensive. So this is sort of an outline of some therapies that can be used for patients with specifically urinary symptoms. One is, we'll go into that more. Next slide, please. So the first one is based off of actually the Chinese acupuncture. It's using a point on the ankle, and it's using a very thin, small acupuncture needle right on the ankle. And this actually, a very smart scientist at University of Michigan studied this and showed that by applying a little electricity to this nerve, it actually helps run interference with an overactive, oversensitive bladder. And this will help expand and relax the bladder. So this is an FDA-approved therapy for the bladder. And it starts by doing one session a week for 30 minutes of electrical stimulation. Next slide, please. It's very safe. It is performed for 12 weekly sessions. So this is great if you have time, if you have somebody who can do this for you who is relatively close to where you live. And then after the 12 weeks, usually it's performed every 2 to 4 weeks. And yes, it has to be done continuously or the effects wear off. So yeah, this has to be continued. One contraindication is if you have a heart pacemaker. Next slide, please. Okay, I'm going to try to wrap up so we can have some time for questions at the end. So I'll go a little bit quicker. Cystoscopy with bladder Botox is using a camera in the office, and we use a very small needle and inject the medicine directly to the bladder. And the medicine is Botox. It's a muscle relaxant. So this helps relax the bladder and increase the bladder capacity. The procedure is very quick. It takes about maybe 5-10 minutes. It can be done in the office. And the medication lasts a lot longer, 6 months, so you don't have to come to the office every week. And it works a lot better than the medicine. Next slide. This is the only therapy that's actually FDA approved for neurogenic bladder. It can last 6 months, sometimes longer. And the risks are often minor and can be managed conservatively. Next slide. And then there's also an office procedure called a nerve evaluation. And this is essentially a test where if we can apply a little bit of electrical stimulation to a nerve on your lower back called S3, if that can relax the bladder, we can do a test drive where you go home with a battery belt. And then after 3 days, sometimes longer, you come back, we take everything out. And if you get great benefits, you'd be a candidate for an operative procedure. Next slide. This is essentially like a bladder pacemaker, the same battery used for the heart. And this is actually FDA approved for the overactive bladder. It's approved for urinary retention. So if your bladder is not releasing urine, and it's also approved for leakage of stool. It is a surgical procedure. It's relatively quite safe, and the battery, if successful, can last 10 to 15 years. So this is your longest lasting option. Next slide. And then there are some more surgical approaches for patients who either don't have the dexterity or perhaps one of these other methods just didn't work well. And essentially, if the patient is really suffering from their symptoms of urine leakage, or if they're just going so frequently that they're having a lot of trouble day to day, there are surgeries where you can redivert the urine. You can do tubes directly into the kidney that drain to bags. You can recreate the bladder using a segment of intestines, and then it drains into a bag. And then you could also expand the bladder. If the bladder doesn't hold a lot of urine, which means you're going every 20 minutes or so, you can expand it with a bowel patch called an augmentation cystoplasty. It is a bigger surgery, but if the surgery is successful, the patient can store urine for much longer periods of time, but catheterization is required. Next slide. And so this is our final slide. We have time for questions, and these are our Twitter pages. And I know you guys are all very tech savvy. Those are the QR codes that link directly to Dr. Gleischer's and my own web profiles at Northwell Health. And I believe I saw a couple questions in the chat already. And so I can answer at least Gloria's about whether insurance covers the procedures, those office procedures that I mentioned. Insurance, the way we usually do it is we check the insurance and we get what's called a prior authorization. So we say this patient is suffering, they're having urine leakage, or they're getting up multiple times at night. They tried one, maybe even 2, 3 medicines, and there was no benefit. Can you authorize them for either the tibial nerve acupuncture stimulation or the bladder Botox or the nerve test to see if they'd be a candidate for the bladder pacemaker? Insurance would then say yes, and then we would schedule it only then. If the insurance says no, sometimes we have to do a very tedious process where we have to appeal it, and sometimes we have to do a peer-to-peer with a doctor who is not a urologist. So this is sort of the system we work in, but most often we can get it approved. And I'll say, honestly, I sometimes have a better, more ease approving some of these therapies than the medications, because the medication pharmacy companies have a very tight hold over some of their costs.
I think there's a couple others. I know I put another one in there myself, which was, do PD medications impact bladder dysfunction directly? So is that a result of the PD medication?
Dr. Gleicher, Dr. Tabakin want to chime in? You know, benztropine is one of the ones that I'm thinking.
The most common carbidopa, levodopa, or Cinemet, generally not. It does have some properties that can impact bladder emptying, and so make it a little harder to empty. But again, the benefit of those medicines far outweighs the potential side effects of urinary symptoms. It more so comes down to when we consider prescribing a medicine, looking at reconciling that with the other medications that a patient's taking to make sure that there are no other, that there aren't, we're not going to increase side effects or worsen current symptoms like cognitive and because there can be some cognitive side effects associated with some of these bladder medications. And so this sort of again reiterates just why it's so important to do bladder testing on patients, because you can have an overactive bladder, feel like you're running to the bathroom around the clock, getting up at night, and this sort of gets into, I think, Jeffrey's question a little bit. Why are you going so frequently? Are you having a hard time emptying? Or is it that your bladder just isn't holding as much as it once was because the nerves are misinterpreting, the signals wrong, because you have underlying neurologic changes. And so it's so important to do testing on the bladder, even if it's just making sure that the patient's emptying appropriately, which we can do easily in our office before we recommend treatments.
Yeah, I'll just chime in. In urology, we often say the brain comes before the bladder. So if the treatment is helping the brain, we can try to work around that and help the bladder. We're sort of given the cards dealt to us.
You know what, if you guys could stop sharing so people can kind of ask questions.
Oh, yeah, sorry.
That might be easier. Thank you so much.
Yeah.
So there's a chance, guys, if you want to put some questions in the chat, or you're also welcome, since there isn't that many of you, if anybody wants to unmute and ask a question, you're certainly more than welcome to do that. But you have a good opportunity to hear three doctors. We're not always so lucky to have three esteemed physicians in one room.
Can I ask a question for my husband?
Go
Yeah,
ahead.
the information you're giving is very interesting. However, the discussion doesn't particularly apply to him, and I'm curious because whether this is part of an issue. The difference is that he no longer is able to urinate except using a catheter. How was either that Parkinson's affected it, or did it is it vice versa? Was that something that occurred because of Parkinson's? We've never even been told this. This entire conversation is so different from what we are hearing. And the other question, I guess the other point is, in order to keep him healthy, the conversation has been whether or not he could only have to do it twice a day or is 3 times a day required for basically scheduling and health reasons.
So this sort of gets into when I was talking a little bit about how it's so important to tease out, what's going on from a bladder standpoint. And so you can see urinary retention for a lot of different reasons, not necessarily just because of Parkinson's. If there's some sort of issue like longstanding obstruction from an enlarged prostate and the bladder doesn't function as well, is it something with the sphincter not relaxing? And so again, that's why it's just so important to do proper testing of the bladder to answer those questions so that we can present with you options. But as far as catheterizations go, and those are a pretty decent option for a lot of patients. Again, with Parkinson's, you have to reconcile that with tremors and dexterity. So that's definitely something we consider. Can you guys hear me?
Yes.
Very well. Thank you.
So that's something that we have to consider when we come up with a regimen like catheterization. Is that the most appropriate option for a patient based on their symptoms, progression of their neurologic disease? And so as far as the number of catheterizations per day, that's usually a conversation with the physician. And it depends on if, one, you're voiding it all during the day. So in between catheterizations, generally what we'll recommend is titrate to fluid intake. And so target volumes becomes important of understanding how much you're catheterizing or how much urine is coming out when you pass in your catheter. The magic number I usually counsel my patients about is somewhere between like around 400 cc's or milliliters. And so when you first set out doing straight catheterizations, I'll usually send people home with some sort of measuring tool so that they can get a sense of how frequently should I be catheterizing. Some people need to catheterize 3 times a day. Some people need to catheterize 4 times a day. Some people are catheterizing 6 times a day. It really comes down to the patient, how much fluid you're taking in, if you're voiding in between catheterizations, and a lot of it's highly individualized. And so, again, it's so important to see someone who can help navigate, and diagnose what exactly is going on. Where's the issue with the bladder? Why isn't it working appropriately? And then what's a feasible management option based on symptoms?
Okay. How easy is it for us to get an appointment with you?
Give us a call. I mean, we are here. We want to see everyone. We want to help everyone. Just call
You
our
work
offices.
Great Neck?
She's the one she's part of Northwell Health, I believe, in both Great Neck and like Success. Okay.
Yeah.
It's a light
And Garden City, I think, for some of them, right?
I'm in Garden City, but we have offices in Garden City, Great Neck, and then Leak Success.
This is an excellent program. Thank you so much.
Aw, so glad.
Can I follow up on my question really quickly?
Go ahead.
The patient who has dementia but has a continuous sensation of wanting to void, let's assume that the bladder testing comes up as normal. Is there some way of training or disconnecting that over sensation? I mean, I know you mentioned about caffeine. I know that she drinks a lot of tea, which has, I'm sure, a lot of caffeine in it. Is there anything other than a dietary or, supplemental way of being able to slow down or deaden or that overstimulation feeling, which has affected her ability to sleep through the night? I mean, basically cannot sleep through the night at all, up hours at a time because of the sensation of having to void, sits in the toilet, can even fall asleep on the toilet because she has that constant overstimulated feeling and probably doesn't have to void in the first place.
Yeah, that's very common. I mean, that sounds like something that we call overactive bladder, which can happen in patients with dementia or without. Anybody can have that. And like I mentioned, we usually do start conservative in terms of like making those fluid changes. Sometimes it's also the amount of fluids that you're drinking as well, in addition to the actual irritants that you may be taking in and not realizing it. If things like that don't work though, and like, regularly going to the bathroom, trying to go to the bathroom after meals, stopping eating and drinking 2 hours before bedtime, if those things don't work, that's kind of when a lot of people would recommend starting a medication. If medications don't work, then some of those procedures are options for patients that have overactive bladder. So if that's, what someone that you care for is dealing with, it's definitely a good indication to see a urologist and see the options that are available.
Thank you.
Anyone else? Any questions? Anybody?
And one question for you. This is being recorded and will be on the website, correct?
It will.
I have to show it to other caretakers, meaning my other brothers, to help our mother with this kind of situation for sure. At 91 years old, they need to not hear it from me. They need to hear it from the professionals.
That's wonderful. I appreciate that. That's a really good idea. We will let other caregivers know that it's on. It will be on the website. So thank you for that. Much appreciated.
Thank you.
Somebody else? Questions? This is your chance, people.
There's a question in the chat.
Yeah, I see that there's a question in the chat. does wearing pads increase the risk of UTIs? What pads are recommended? In my personal experience, and Dr. Gleischer, Dr. Lee, please chime in. A lot of times what I see from pads, women and men who wear pads, not necessarily urinary tract infections, but sometimes their skin can become extremely irritated and lead to like yeast infections and other sort of skin sort of infections or irritation. Typically what we recommend in this situation is on the pad that they apply some sort of barrier cream. So that's usually like Aquaphor or a diaper paste, triple paste ointment. We have them apply it to the pad as a barrier. So when you do leak urine, if you leak urine and you're choosing to manage it with pads, the barrier cream prevents it from getting on your skin, which can really help alleviate some of those symptoms of that itching and even burning on your skin.
I would just add to that, the underlying concern is also if you have a patient who's, let's say, using diapers and pads and leaking a lot of urine, there is something we didn't really touch upon, which is called overflow incontinence, which means that sometimes patients pee because their bladder's so full of urine that eventually the pressure pushes some of that urine out. But overall, the bladder's not emptying very well. And if you have a bladder that doesn't empty well, it's kind of like a cup on the kitchen counter where you fill it with milk and you only drink half every day and you just keep refilling it. That leftover gets spoiled and gets infected. So sometimes for patients like this, it's very important that we not just look into their leakage, but make sure that they're emptying okay and safely.
And also
what would you do for that though, Dr. Lee? Let's say, let's say somebody's not able to empty that small amount each time.
How do you treat?
How would you treat that?
That's a good question. A lot of it depends on why. So let's say like what Dr. Gleischer said, it's a man who has a big prostate and his bladder is still working, then that could be the solution. But let's say it's another patient who just doesn't, maybe their bladder kind of is overly distended and doesn't empty well. Sometimes a urinary catheter of some sort, or even what we call intermittent catheterization, might be the most effective approach, even though it doesn't sound very exciting, at least it's safe. And then for the patient who's got very good hands, very motivated, the bladder pacemaker actually has some success. It's FDA approved for this is called urinary retention. So if there's a patient who wants to give it a try, you can try the bladder pacemaker and see if they can empty their bladder better. It's not always 100%, but better.
Thank you.
It's Natalia. This is a really great presentation. Can you hear me?
Yes.
Great. Okay. I just wanted to say that the problem with my husband is getting him into his urologist's office. He already has the enlarged prostate, and starting about 5 years ago was when we didn't go, because first it was a dementia diagnosed, early cognitive decline, and then it was COVID, and then it was worse dementia. So that now he's having the urinary urgency and incontinence that way. Sometimes he can't make it to the bathroom in time. He's self-care that way. And keep reminding him that, you already had a urologist. This is something that we were already going, and we hadn't been able to, and now we need to start going back to that, because, maybe you can get used to be on a medication, maybe it's prostatitis or whatever, And so far, made 3 appointments because of that to cancel 2 because they refused to go. So we're working on it. see if this time next week I can, like get him in the door. So it's just, I mention it because, right, the dementia and the urology problem and trying to deal with the urology problem when he has the dementia. So
True. So true. Well, the question is, how do you get them there, knowing they need it? And I'm sure that, that you're probably not everyone's number one on the list, guys, of where they want to come to, right? So the question is, how do you get someone there who might have some resistance? What do you think?
Well, I feel like the key is just that, like, getting them there, that like initial visit, so we can get the important answers. Why do they have an overactive bladder? Are they not emptying okay, or are they going too well and too frequently? And then I have a lot of patients who have transportation issues, mobility issues, and we do telehealths and we check in and we talk about things. Once we have that information and we sort of understand what's going on, I know it's so tricky, but and it can be challenging even just from like a transportation, like logistics standpoint. But if there's some way, to remind them, we're gonna go and maybe get help and remind them of their symptoms. I know it's super challenging. But again, if you can have that breakthrough of just getting them to the office, a lot of times we're willing to do telehealth. I do a lot of telehealth just because of the circumstances, and so we try to make it work within, we try to make it work.
That's a good question,
Thank you.
Medalia. Somebody else? Questions? Well, it's after 3, and we've gotten lots and lots of information that we all have to absorb, right? Lots to think about and to learn. And it will be on our website if you need to review the slides. I know I'm going to need to review them because it was lots and lots of good information. I want to thank Drs. Gleischer, Tabakin, and Lee so much for coming and doing a wonderful, wonderful presentation on a really important and difficult topic. And so we're so grateful that you were here. If anybody has any questions or want to get in touch with the doctors, you certainly can email me and I will pass on that information if you want to get in touch with them. Hopefully everyone will have a good rest of weekend and day. So I wish you all well. All right, take care, everybody. Thank you again, guys.
Thank you.
Thank you so much. It's been great.
Thank you for being here. Thank you so much.
Oh, can you post the link to your website?
Gloria, it just looks like someone
wanted
a link to the website.
Okay, I have put it on, but I'll put it on again quickly before I get out. Oh, I just put them to our website. Let me do it right now. It's www.freeburgjcc.org.
And you just have to give us a couple of days till it's on the website, the recording.
Just freeburgjcc.org. Pretty easy. And if you don't, just email me. Everyone has my email. You certainly can get in touch. Or Caitlin. You have either my or Caitlin's email or Pam's, and we'll get it to you. Okay.
All in here.
All right, everyone. Take care.
Bye-bye, everyone.